All right, everybody. So thanks for coming on early today, making a special effort to meet with a very special speaker. So today we're welcoming Dr. Michele Brignole, who is coming to us from across the pond in Italy. So Dr. Brignole is the former director of the cardiology department at Ospedale del Teguglio. I don't know if I'm saying that correctly or not.
Correctly, you have said correctly.
Good, in Lavagna, Italy. He's currently the coordinator of the Faint and Fall program at the IRCCS Istituto Oxologico in Milan. His main fields of research are diagnosis, pathophysiology, therapy of syncope, and rhythm disturbances in catheter ablation of arrhythmias. He's also served as the chairman of the guidelines on syncope of the European Society of Cardiology and chairman of the guidelines on cardiac pacing and cardiac resynchronization therapy of the European Society of Cardiology, as well as a member of the guidelines committee on cardiac pacing and cardiac resynchronization therapy of the European Society of Cardiology. So we're really excited today to be able to talk to Dr. Brignole about the trial that he has here on the screen. It was something that was presented at the European Society of Cardiology meeting earlier this year, and is something that I think as heart failure physicians, we tend to come across probably more often than not about what to do with our patients that have permanent atrial fibrillation and trying to understand the benefits of rhythm versus rate versus maybe device. And he was the lead author on this paper that really was quite remarkable and uncovered what I think to be a very helpful result. I actually have a patient here in the hospital now, Dr. Brignole, that is in this exact situation. And as I'll let you know, he's going to be going for AV nodal ablation on Friday, I think. So your work is making a difference already. So with that being said, I'd like to turn it over to Dr. Brignole, and the floor is yours, sir.
Okay. First of all, let me thank you for this invitation. I feel myself honored to be invited by a so prestigious university, and greetings for Italy. Greetings for Italy. So my speech today is the result of APAF-CRT mortality trial. You can see it has been just published online in European Journal this year. The background for this trial is that we are not happy with pharmacological therapy of atrial fibrillation and heart failure. The RACE2 trial showed that a strict rate control, less than 80 beats per minute, was not better than a lenient rate control in patients with AF, and even a little bit worse as regards the composite of cardiovascular death, heart failure hospitalization, stroke, systemic embolus, bleeding, and life-threatening arrhythmias. Also, beta blockers are not so effective in patients with atrial fibrillation as they are in patients sinus rhythm. In this meta-analysis of the major randomized trial, published randomized trial, you can see that mortality in atrial fibrillation was not affected by beta blocker therapy, contrary to the benefit obtained in sinus rhythm. Also, digoxin has a neutral effect in survival in patients with AF and atrial fibrillation, even if it had a mild benefit, it provided a mild benefit as regard hospitalization and worsening heart failure. Also, AV node junction ablation and apical right ventricular pacing was unable to improve survival. In this old trial, there was no benefit of ablation compared to drug therapy in 6 years of follow-up. Even if AV node ablation and right apical ventricular pacing proved to be effective in improving quality of life compared to drug therapy. You can see there are 5 randomized trials published before 2011, and the majority of these showed some benefit in quality of life and symptoms. In 2011, we compared apical right ventricular pacing and AV junction ablation with CRT biventricular pacing and AV junction ablation. And we were able to show a benefit of the primary endpoint, the primary combining endpoint of death for heart failure or hospitalization for heart failure or worsening heart failure in patients treated with CRT compared to those treated with right ventricular pacing. At 2 years, the cumulative incidence of the primary endpoint decreased from 34% with right ventricular apical pacing to 14% with biventricular pacing, with a relative risk reduction of 63%. For this, with this background, the study hypothesis of the APAF-CRT trials was that the rate control by AV junction ablation and biventricular pacing is superior to rate control by pharmacological therapy in patients with severely symptomatic permanent atrial fibrillation lasting more than 6 months, unsuitable for AF ablation, or in which AF ablation had failed, and narrow QRS, namely less than 110 milliseconds, and, this is very important, at least 1 hospitalization for heart failure in the previous year. The APAF-CRT project consists of 2 studies, the Morbidity trial and the Mortality trial. The enrollment of both mortality and morbidity phases started in October 2014. In May 2018, the morbidity phases was terminated when the primary endpoint of hospitalization for heart failure and worsening heart failure showed a clear benefit of ablation and CRT versus drug therapy with a hazard ratio of 0.38. The recruitment continued for the mortality phases until December 2020, when at the interim analysis, the event and data safety monitoring board decided to stop the trial that was actually closed on February 2001. And the primary endpoint of death from any cause was reached. The APAF-CRT trial is a multi-center, international, prospective, randomized, parallel, open-label trial with a blinded outcome adjudicated by an external blind clinical event committee. The primary outcome of mortality phase was death from any cause, and the secondary outcome of mortality phase was death from any cause or hospitalization for heart failure. 140 patients were randomized 1-to-1 to ablation plus CRT plus ICD according guideline, or to rate control drugs plus ICD according guideline. The randomization was pre-stratified by center and by ejection fraction less or more than 35%. Therapy was optimized at 30 days after randomization, and patients were followed up each year up to 4 years. The average age of this patient was 72, 74 years. 56% were males. The duration of permanent atrial fibrillation was 19 months. Previous attempts of catheter ablation were made in 80%, and the patient in the previous year had 1.5 hospitalization for heart failure. NIA class more or equal to 3 was present in 2/3 of the patient, and the specific symptom scale score, the quality of life score, was 28 out of 60. The average heart rate at enrollment was 100 beats per minute, and the QRS length was 95 milliseconds. The mean ejection fraction was 41%. After the therapy was well balanced at randomization, and 30 days, 1 month after randomization, after the optimization therapy, these were the rate of the optimal medical therapy. The therapy remained well balanced except for the digoxin that was higher in the drug arm. And there was also not significant higher rate of amiodarone, sotalol, and beta blockers in the drug arm. At the end of 30-day period optimization, the heart rate was 70 in ablation and CRT arm and 82 in the drug arm. So we achieved what it was called in race 2 a strict rate control target. So to summarize, 130 patients had permanent AF, narrow QRS, 1 or more heart failure hospitalization during the previous year and severe symptoms. 63 were randomized to rate control with ablate and CRT, and 70 to rate control with drugs. The average rate was 70 versus 82, and at a median of 29 months of follow-up, death from any causes had occurred in 7 patients in the active arm and 20 patients in the control arm, 11 versus 29%. This corresponded to an estimated Kaplan-Meier survival curves of death from any cause of 14% in ablation pacemaker arm versus 41% in the drug arm. This means a relative risk reduction 74%, an absolute risk reduction 27%, and the number needed to treat of 3.7. The difference, of course, was highly significant. First of all, I wanted to discuss with you one criticism, one problem arises from this trial, the problem of generalizability. Since the trial enrolled was small, enrolled only 60, 70 patients. So if you look in Sweden, a registry of 270,000 patients that are the nationwide long-term registry, all the patients in Sweden who were hospitalized for the first time with atrial fibrillation, we can see that the survival rate at 4 years in the Swedish arm was around a little bit less than 40%, not much different for the 40% death rate in the our drug arm. In addition, the mean age was exactly the same of the APAF-CRT, 72 years, as well as the male prevalence. So we can say that despite the small number of the APAF-CRT, these patients are representative of the general population, the Swedish general population of patients affected by atrial fibrillation, heart failure, and who were hospitalized for this reason. The secondary endpoint of death of any cause or hospitalization for heart failure confirmed the result of morbidity trial, expanded to 4 years. There was less death and hospitalization ablation pacemaker arm than with drug arm, with a relative risk reduction of 60% at 4 years. The predefined left ventricular ejection fraction analysis gave important result because we could stratify, distinguish the result in the patient with reduced ejection fraction, on average 29%, versus the patient with preserved or mild reduced ejection fraction, on average 49%. As you can see, the two figures are very similar, show very similar result, with a benefit similar in patient with reduced, in patient with preserved ejection fraction. And in patient with preserved ejection fraction, the difference was highly significant with a hazard ratio of 0.27. These results are quite surprising, but not too much. For example, in the morbidity phase, in which we analyze as a secondary endpoint the quality of life, the symptom and physical examination, we already showed that the subgroup that had the best improvement in symptom were the patient with a preserved ejection fraction who had underwent ablation CRT compared to the other three groups. Similarly, in the previous APAF trial, again, we were able to show a benefit in the primary composite endpoint, also in a subgroup that we have defined offline off guideline because they had preserved ejection fraction or narrow QRS or a New York class less than 3. So did not meet the usual criteria of the guideline for CRT of the patient sinus rhythm. Of course, the event rate was less in the patient with preserved ejection fraction compared to the other group, but the hazard ratio was very similar, 0.41 versus 0.32. And finally, in the sub-analysis of the Cabana trial, a patient will receive AF ablation, the subgroup of the patient with heart failure, defined as age-more heart failure in patient as class New York class equal or more than 2, in patient age more than 65, and or in patient less than 65 plus on a risk failure. Again, in the Cabana trial, we observed the same result. The benefit was higher in patient with preserved ejection fraction compared to the patient with depressed ejection fraction. So the results are consistent. There was no interaction in the APAF-CRT as regards age, sex, body mass index, heart rate, coronary artery disease, New York class, a specific symptom scale score. There was an interaction with digoxin, but it was a reverse interaction. The patient with digoxin, of course, were more patients in the drug arm were taking digoxin. And digoxin showed a benefit compared to patients not taking digoxin. There was no interaction as regards the baseline eye rate. The patient with ablated CRT had a better outcome irrespective compared to drug arm, irrespective of their baseline heart rate. So the main conclusion of the APAF-CRT are summarized in this slide. Rate control by ablation SRT was superior to rate control by pharmacological therapy in reducing mortality in patients with permanent AF and narrow QRS. The benefit was observed in patients with preserved ejection fraction with no interaction between patients with ejection fraction more or less than 35%. The benefit was due to the combination of the strict rate control and rate regularization achieved by V-junction ablation, together with biventricular pacing, which counteracted the adverse effect of non-physiological right ventricular pacing. APAF-CRT trial results support ablation SRT as a first-line therapy in patients with permanent AF, narrow QRS, who were hospitalized for heart failure. The publication of the APAF-CRT was accompanied by an editorial by Cecilia Linde that I would like to show you in brief. Professor Linde compared 3 therapies for permanent atrial fibrillation: pulmonary vein isolation, AV junction ablation SRT pacing, and pharmacological rate control, beta blockers, digoxin, and amiodarone. The indications are quite different. Indeed, pulmonary vein ablation isolation is indicating younger patients with severe symptoms, tachycardia-mediated cardiomyopathy, and heart failure with reduced ejection fraction. Contrary, all the V-junction SRT is indicating older patients who have had an hospitalization for heart failure, either in patients with reduced or preserved ejection fraction, and irrespective of QRS duration. Pharmacological rate control may be still indicated to control insufficient rate high rate patient with high rate in either reduced or preserved ejection fraction who are able to tolerate such drugs. The benefit of improved mortality and morbidity and symptom either with PVI ablation and with V-junction ablation, whereas drug therapy never were proven to be useful to reduce mortality. The negative effect of PVI ablation are procedure-related complications and relapse recurrence of atrial fibrillation in about 50% of cases. The negative effect of V-junction ablation are pacemaker dependency, and the negative effect of pharmacological rate control are inability to achieve rate control and the adverse effect of the drugs. The gaps in knowledge is the lack of a trial that compare PVI ablation with ablation CRT and the potential eventual improvement with is bundle pacing. I stop here my presentation, and I hope you have enjoyed it, and I'm waiting for your comment and the question. Thank you.
Thank you so much, Dr. Brignole. This last slide answered so many questions that I was thinking about as you were speaking, so I'm really grateful you shared this. Among the group, does anybody have any questions for Dr. Brignole that they'd like to ask? You can feel free just to unmute yourself and take your time to ask any questions that you might have on your mind. All right, well, I have a question then, I guess, while others are thinking of something. So looking at this last slide that you have up, you know, I guess, correct me if I'm wrong, because I'm not familiar with all of the literature as much as you would be, not even close to be. So how would you apply this to, I guess, you know, because in your study you were looking at patients with permanent atrial fibrillation. But you know, if we're looking at trying to do something like pulmonary vein isolation, I guess by definition, you know, somebody would have to have failed PVI prior to becoming labeled with permanent atrial fibrillation, or would you know, clinically just think that that might not be a viable option for somebody? I'm guessing where I'm coming from is how would you make the determination in a patient that maybe, you know, has been having difficult to control atrial fibrillation and pursuing PVI versus thinking, and I know this is in the bottom here, this is one of the things that needs to be, you know, still looked into. Comparing that versus when would you then just move to AV nodal ablation and CRT pacing? Like what would be your threshold in a clinical situation?
Only few patients, less than 10%, had failed PVI ablation before undergoing AV nodal ablation CRT. So the overlap between the two procedures was very small. This is not surprising for me. Maybe it can surprise some other, because if you look at the inclusion criteria of the Cabana trial and of the Castle trial and the inclusion criteria of the APAF-CRT, we can see that the two populations are completely different. For example, there is a difference of more than 10 years in age. The average age of PVI ablation is less than 60. The average age in APAF-CRT was 72. So it seems that the indication that the two procedures are both excellent procedures because save life, improve quality of life, but are indicated for different kind of patient, for a different population. Is this what you asked me?
Yes, no, that's very helpful. Thank you.
Since I was waiting a discussion on this topic, let me show some extra slide that I have prepared.
Thank you, that'd be wonderful.
At this regard. The first slide that I want to show you is a comparison between the Castle AF and the APAF-CRT. As I said, the two populations cannot be compared, are not comparable for the reason that I have mentioned. Anyway, if we look to the death of any causes in the two trials, we see that was the hazard ratio of the APAF was much better than the hazard ratio of the Castle. The hazard ratio of the Castle was 0.53 and the double of the hazard ratio of the APAF-CRT mortality. Of course, maintaining sinus rhythm is much better than controlling rate with a biventricular pacing. I expect that maintaining sinus rhythm should have given better result than AV junction ablation and biventricular pacing. So why this was not the case? My explanation is that in Castle IF, 50% of the patient had a recurrence of atrial fibrillation. So PVI ablation failed in so severe patient with heart failure. And this 50% recurrence of atrial fibrillation is exactly the 50% less of benefit of the castle trial compared to the CRT. In other words, if with PVI ablation, we would be able to achieve 100% rhythm control, the benefit would have been double, exactly as APAF-CRT. The same reasoning apply to the Cabana. The Cabana HF, the subgroup of the patient of the Cabana that were classified as affected by heart failure, again, showed less good result than the APAF-CRT. The hazard ratio was again 0.57, very similar to the castle. And again, if we look at Cabana, approximately half of the patient failed to maintain sinus rhythm at 5 years of follow-up. So this is my explanation of the different result of AV node ablation that achieve a 100% rate regularization versus PVI that is can be effective only in 50% of the total population.
It's very amazing that you had anticipated that question so well. Is there anybody else out there that has anything they want to ask or any comments?
Hey, Mike, it's Sam Hahn. Thank you very much for the excellent presentation. You know, I'm not a heart failure specialist, and I've been aware of these studies kind of in the background, but the mortality reductions are very impressive, much more so than I would have guessed, and certainly seems to beat a lot of the mortality benefit we do for a lot of things. How aggressive are you with this strategy now? And also kind of as a corollary to that, you know, the deaths were from all causes. What were the deaths from? Were they from heart failure? Were they from what was the nature of the mortality benefit? As I said, it's very impressive.
Yes, thank you. This is very important question. Actually, many patients did not die of cardiovascular cause. Approximately in the supplement, we can find in the supplement the exact figures. There is a table with the exact figure, but just for this discussion, you can say that two-thirds had the final diagnosis adjudicated by adjudication committee as cardiovascular, and 1/3, probably 40%, non-cardiovascular. The few patients die of cancer, other patients die of infection, and so on. How to explain the result? Because of this population. This is a population, it is not 100% cardiac. These patients are old, are multiple pathologies. Atrial fibrillation is not the principal disease. Is associated to other diseases, also non-cardiac. And this is the reason, and again, this explains why the benefit was observed in patients with preserved ejection fraction, as well as in patients with depressed. So this population, very old patient, very severely old patient, is completely different from the population or failure in sinus rhythm that we are used to see in cardiology department. Indeed, electrophysiologists do not see this patient very frequently. This patient come to electrophysiology as a second, third step after they have been evaluated by internist. So you have to think to this patient, different from the usual patient that we see in CCU. Or the usual patient who have heart failure in heart failure clinic that have sinus rhythm. And atrial fibrillation is an associated disease, important because worsen the prognosis. If you avoid the atrial fibrillation, things improve a lot. The patient do not die, but is associated to other comorbidities. This is my explanation.
Thank you very much.
In other way, is like a patient died by COVID or died with COVID. This is an actual debate, no? A patient who died with COVID or because of COVID. This is the same. The patient died for atrial fibrillation, or atrial fibrillation simply worsen another disease. This is the point. This is my point.
And have you been using this strategy much more frequently now then? Or how has this affected your practice?
No, not very frequent, because these are very selected. They have permanent atrial fibrillation refractory to pharmacological drug, and have had an hospitalization for heart failure in the previous year. They are not so frequent. They are not so frequent. They are selected. On average, in my hospital, in Lavagna Hospital, which is a small, medium-sized hospital, not a big tertiary university center, I perform usually 10 procedures per year, no more. But as I said, the number of patient candidates for this are much, much higher, because these patients usually are not referred to electrophysiologists, and not even to cardiology department. These patients are referred to internal medicine, to medicine world. And many of these patients are outpatient. These are not the usual patients that are seen in a big tertiary cardiology university. We have to look for this. We need to make education, to change the pathway, the internal protocols. If you do this, the number increases largely.
I wanted to ask you a little bit more about moving on from PVI. Like in your trial that you presented, the patients on average had failed PVI 5 times, I believe is what the data was that you shared. I guess at what, to me as a heart failure doctor, I don't know, that seems like a lot of attempts at a therapy that's not working. When would you, I guess, how many attempts at PVI for a patient with heart failure with reduced ejection fraction would you recommend making before you would transition to AV nodal ablation?
Two procedures.
Two.
I don't think that the third procedure may be beneficial. But as I said, the overlap is minimal. The overlap is minimal because even if PVI ablation fails, symptom improves, the quality of life is better. So the patient and the doctor are reluctant to move toward the destructive procedures like AV node ablation and CRT implantation. They are young, more than 10 years younger So I don't see a great overlap between the two procedures. I don't see the need to pass from one procedure to the other in the majority of cases. I could say that a patient who failed a PVI ablation will undergo a V-node ablation SRT 10 years later than we perform a PVI ablation, not immediately. This is just to give an idea. Of course, there are any patient is individual is different from the others, but just to explain what I think.
So I'll open it up again for any questions. If anybody has anything before we wrap up. All right, well, not. So Dr. Brignole, thank you again so much for taking the time out of your day to join us and you know, share this work and really help us to understand these complex clinical decisions in a way that's much more clear and helpful for us delivering care for our patients. Thank you so much. I hope one day, you know, when COVID is a little less of a problem, you do get to come back and visit America and we get to meet you sometime.
Yes, I hope. Thank you very much. Have a nice day.
All right, bye-bye.
Goodbye.